Okay, so so this is a modified version of a talk that I commonly give, and schistosomes are helminths. So that's not and they're almost always parasitic. They're usually flattened and they have no body cavity. So remember, nematodes have a body cavity. They're much more advanced than trematodes. They have one or more suckers. They're usually hermaphroditic, with the exception of schistosomes. So actually, schistosomes are really quite different than the normal trematodes. They have a blind intestine and no anus, so everything they take in is expelled from their mouth, and this goes directly into the bloodstream, as you would see. And they're digenetic, that is, they have alteration of close and molluscan in the human form. Now, not all trematodes are digenetic, but the ones in humans are. So this is just to show you, give you an idea of the types of parasites these are. So these are the hermaphroditic type right here, and these are either in the biliary tract or in the intestine. The schistosomes are different, and you can see the male schistosome is here, and the female is in it's called the gynecophical canal. And as a matter of fact, the word schistosome comes from the word schism, because it's a split in the male, and the female is spends its entire life in copula with that male. They can sometimes switch, but so there are a number of species and subspecies of schistosomes, and the most common one, and the one that is most commonly studied, is S. mansoni, and Japonicum and Hematobium. That's the English spelling of Hematobium. So there are a bunch of minor species, Schistosoma macrongae and Schistosoma intercalatum. And there's some other minor species in addition, and they're mixed species. So sometimes the species, the worms can cross. They would cross. So Hematobium will mate with a mansoni, and so on and so forth. So they're different than all the other trematodes, as I was alluding to. The sexes are separate throughout life. So you can have a male and female Veracidia. That's the form that comes out of the egg. You can have male and female Security, and you can have male and female, and you do have male and female adult worms. And this is different from all of the other types of trematodes. The adults are round and not flat, so they actually look like worms, like we commonly think of. And the adults are in the vasculature. I have to tell you that when I was a fellow and deciding to go into the lab, I went into the parasitology lab, and they were perfusing mice that were infected. And it was the most amazing. I still remember to this day the worms that were being flushed out of the vasculature to study. And this poor little mouse had 120 or so pairs of worms. And they're about the size of your pinky in length. They're very small. They're not very wide. And you can imagine someone having 3,000, 4,000 of these things running around their body. That would be a very heavy infection, but it clearly documented. So what would a lecture in parasitology be without a life cycle? So this is the character. This is the life cycle. So the one acquires the infection from bathing in infected water, and the water contains Security. This is released from a snail. It's a freshwater snail, but there are also saltwater varieties of other animals. So it causes things like clam digger's itch and so on and so forth. So, but what happens is Security goes through the skin. They're not really good at it In contrast with the strongyloides, for instance, I did this experiment. In fact, just putting a rat skin and watching it or studying it, how it migrates through the skin. Schistosomes take several hours, and in the process of going through the skin, they form schistosomule, which this is an older schistosomule here. The tail is left out. The tail falls off before they invade. And strongyloides, for instance, goes through in a few seconds. So they're really fast, and schistosomes are very slow, and they're also very inefficient in what they do. The sommule, the tail is to move. The tail is, it pops off.
Why is that there? To move?
So yeah, well, these are in the water, and they move. They have a very, when you look at them, they have a flipping action that whips back and forth, and that's how they move. They're not very long lived. They last at most a day, but usually it's just a few hours, and then they peter out. So they have to do their invasion pretty fast. They're in the skin for a few days, and then they migrate through the lungs, and they burrow into the vasculature there, and then end up in the liver 3 days onward. And they're usually in the major portal veins. They stay there and then eventually mate, and then head down towards the tissues. They're actually circulating in the blood, and then as they get into the right area, they tend to stay there. But they're very inexact about where they stay, and you get ectopic disease in different organs really commonly, and also the intestinal varieties. For instance, 10% of the intestinal varieties end up in the bladder. So it's not exact. It's not an exact migration. They're very poor at figuring out where they're supposed to be. Here is just showing you the actual form. So this is a security. This is developing security. Does anybody know what this black stuff is? So the developing worm and the adult worms ingest red cells, and they ingest serum. And this is called hemozoin. It's exactly the same pigment that's in malaria. And you can see that, and you can see it's in the developing intestine. Here is the worms and copula, as I showed you, and this is a mature egg. Eggs are not laid mature; they're laid immaturely, and it takes about 6 days or so, if I recall correctly, to develop into a mature egg. The immature eggs that I'll show you later are not antigenic. It's only when they develop they start secreting antigens and have antigens that they're developed. And these eggs are then deposited in the tissues and form the granulomatous response. Okay, so this is an obligatory slide about where the geographic locations of schistosomes. Essentially, it started in Africa and then developed later. And you can see that the epicenter really of schistosomiasis is in the Sudan and Egypt, where there's more schistosomiasis than you could possibly believe. I worked in both places, and I can tell you that in Sudan, it was a major health problem. And of course, it's present throughout Africa. There's a species intercalatin, which is right in here, and it's sporadic. It's a very focal disease, focal infection, actually. So you can have a small stream, for instance, or a body of water that's really heavily infected, and then you can go just a little bit of ways, and it has to do with the habitat of the snails and how fast the water is going, and so on and so forth. I should say the Asian varieties are here. There's still quite a lot of disease in the Philippines, and of course China is very well known for it. But almost everybody in China has been treated multiple times. Very hard to say what the epidemiology is. We'll talk about that later. And Japonicum, there isn't any in Japan anymore. It's not. There's no transmission going on. And I think probably all the other guys that had it will die off. So the patency. So what do we mean by patency? That means egg laying. So and that's the way you traditionally make the diagnosis. And so and the schistosome varieties that are usually studied, which is the Puerto Rican strain, it's called PR1. That has a patency of 28 days. So at 28 days, they start laying eggs, and it takes 2 weeks for the eggs to first develop and then be extruded into the feces. So you can't make a diagnosis of early disease until at least 6 weeks. And sometimes it's even longer. The patency in hematobium is much longer, and that's in the order of 3 or 4 months. So you're not going to make a diagnosis in that disease, in that infection, until somewhat, or quite a bit later. You have to start wait. This is not unusual in parasitology. The incubation period, that is when disease occurs, is actually quite early, and that can occur before egg laying, and we call that Katayama fever or acute schistosomiasis, depending on your bent. Paired worms deposit eggs in tissues that then it's incite a granulomatous response, and that's the major pathophysiology, although I think it's not, at least as far as a liver disease, it's likely but not totally proven. Their eggs then make their way into the hollow viscus, or they stay in the tissues, and if they're in the hollow viscus, they're then extruded, and then that's how you make the diagnosis. The pathophysiology is actually much more complex, but in chronic disease, it's mostly felt and it's most easily understood as an inflammation, as a chronic granulomatous inflammation, and the resulting fibrosis directed to the eggs. So the eggs, you probably even remember from medical school, you probably had 2 or 3 days of parasitology. So that's probably even a lot. I actually had 3 months of parasitology, so it was way ahead to 50 years ago, or I guess it was 60 years ago now. So Manzanite has a lateral spine, and as I said, the Miracidia, if you do look at this enough, which I have to say I did, you could tell the Miracidia. You could tell whether it's alive. You could tell whether it's dead. You could tell whether it's mature and immature. That takes some experience, and you actually can see in fresh specimens. You can see flame cells. So these are rudimentary excretory organelles, and you can see this. And this is what traditionally you have to tell whether an egg is alive or dead, because you actually do excrete dead eggs, because these are, remember, the eggs are retained in the tissue, and then they're shed periodically, when the tissue is shed. And so it's common to find a few eggs, and people don't say, oh, this patient is infected. Well, he was infected, but the eggs are all dead. So in the old days, when we had to know all this stuff, you actually needed to know whether the patient had an active infection or an inactive infection. The hematobium has a terminal spine. Here, it's not a very prominent spine. They differ a little bit in morphology depending on where they are. And this is actually a picture of a congy, but you can't really tell the difference. Macangi is a little smaller than Japonicum, but they more or less look the same. They have a residual spine, which you can't really see here. So they differ, the species differ in obviously in the morphology of both the worm and the ova. The snail intermediate hosts are really important, and in this particular disease, like a malaria, people are just studying snail, it's called malacology. And they're just studying snails and how they're infected and how they're resistant. And there's actually, when I came here, there was a person who developed the field of snail genetics. And it's actually a very important, turns out that you can't really kill snails very well. And the control of snail populations was the original way people tried to control infection. And it turns out that snails do things like so they can self-infect themselves and selfing, and so it's really hard to kill every last snail, more or less. It takes a tremendous amount of effort, and it turned out to be too much effort in most circumstances. They differ obviously in tissue tropism, where the adults hang out, egg laying, the number of eggs, they range from about 300 or so in Manzoni to 3,000 a day in Japonicum, and the manner, they either are laid singly or in clutches. The eggs also have a different propensity to calcify, where Manzoni doesn't calcify very much, but Hematobium and Japonicum do. And the propensity to cause liver disease is another big difference, and also susceptibility to the drugs. These days, we don't worry about susceptibility to the drugs because we only use essentially one drug. But in the olden days, we had there was really a difference between them. But just to mention that there is still a susceptibility difference between the species of Prosiquana. So this is generally the way I think of it, and it's been modified over the years. So in general, when you see a person, they're either going to have acute disease or they're going to be asymptomatic. And even from early on, you're going to either have, if you're infected and you're naive, in other words, you've never been in the country or you've never been infected, you're either going to have acute disease or you're going to be asymptomatic. And then after that, and there's a number of years, in the course of a decade or so, there's a developmental period. It's not that nothing has happened, it's just that usually, but not always, the patient is relatively asymptomatic. Now you may have some GI problems, your liver is getting bigger, a lot of things are happening. But in general, most of the patients are asymptomatic and they go about their lives. And it's very hard to tell just by looking at them if something's wrong. And then after a long time, and we'll get to this in a second, you still have no disease, or you develop liver fibrosis or esophageal varices. And that is the one thing that is the most important to understand. In intestinal schistosomiasis, you're basically going to live and do okay, with some minor exceptions, if you don't develop liver disease. If you develop significant liver disease, your chances of dying significantly increase, and also of getting all the types of other problems that you can get. So the liver disease is very peculiar. We'll get into that. It's called either periportal fibrosis or Symmers, who first described this. He was an English pathologist living in the early 1900s. And that really determines the morbidity and mortality. The asymptomatic period, people have done a lot of things in people that were heavily infected. It used to be an issue about, and to figure out daily. So there's a little I consider it sort of a joke. Everybody wants to have more dailies. They want more dailies so they can get more money. And so it's a little joke about how many dailies can I get. But at any rate, that's one of the things that they're looking to see whether they should treat everybody because they increase their performance and the risk of disease. Okay, so one of the things that in parasitology, particularly in helminth disease, but to some degree in protozoa also, you need to distinguish who's infected and when they were infected, because actually the clinical presentations are really quite different, and what you do is somewhat different. So the early traveler, for instance, the Peace Corps volunteer, which is the traditional person that we used to see here, I saw actually when I first came here, the only infection that we saw, parasitic infection, was not the only one, but 90% was schistosomiasis. And the reason is that you had to admit the patient, you had to give them IM or IV drug, and they had to be monitored very closely. Praziquantel, when it came, which was 10 years later, over 10 years later, was clearly a miracle drug. And actually, instead of ivermectin, they should have given the Nobel Prize to the developers of Praziquantel. It was not expedient for them for a number of reasons. At any rate, the traveler is usually an adult instead of a child, and that probably makes a big difference. The exposure is limited from one time to a few months and maybe a year or so. The intensity is variable because obviously their exposures are somewhat less. The exposure frequency is 1 to a limited number of exposures, let's say. And this is the group that gets acute febrile disease that is apt to get acute febrile disease in endemic areas. In Manson, almost no one who is infected ever gets acute disease. It's only naive traveler, naive person. And the exception to that is Japonicum. Japonicum is different because it's such a virulent disease that if you get reinfected, you actually do get sick again. And that's not well documented in the literature, but it's at least written in the literature. But if you went to see a case of who actually did that, you would be hard-pressed to find one. The endemic is more or less just the opposite of what I was just saying. It's a lifelong trickle exposure. The intensity infections are usually much higher. And there's usually no acute disease, with the exception that I mentioned. So you need to know that for a number of different reasons, and I'll get into that in a second. So most disease, as I mentioned, is due to the ova, to infection to the ova. The exception to that is acute disease, which is due to actually the adult worms. The ova are immature, and then mature when they're over a week or so, and then they develop their energetic. They are able to produce antigen, which is then reacted to by the host. Morbidity is intensity related. And when I first started, we didn't want to use these very toxic drugs. So we actually set a limit on people that we would treat. So the thing about schistosomes is that they don't excrete a huge amount of eggs. And this is a problem with detection. So what's the limit? Does anybody know here how a stool exam is looked at? You know what somebody does with it when you send it down?
Put a drop on the slide and look at it under the microscope with iodine.
Well, that's one of the things.
And then the other thing is a trichrome stain after fixing. But you have to spin the stool first to separate the fat.
Okay, so there's several things you can do. So the first thing is you make a smear, and you do this, and you stain that. So you look at it fresh to see if something's moving. So you do that to look for amino, things like that are moving around or easy to see. Then you stain the slide so that you can see morphology better. Okay, that's the first thing you do. The second thing you do is you do concentrate, because these ova may not be shedding in large numbers. So the reason I use 1 after 20 milligrams, 1 after 20 milligrams is that's the limit of detection in a standard concentrate. In a standard concentrate. So schistosomes, 500 eggs per gram is a heavy infection. 1 egg per 20 milligrams is a low infection. So 20 eggs per gram, is a low infection. So those are sort of the limits of what I decided. So the ova end up in the liver, intestines, urinary tract, but in actuality, the ova are found everywhere. So we used to commonly perfuse. My boss perfused, did studies. Alan Cheever, who taught me everything he knew, and had encyclopedic knowledge of schistosomiasis. There's no one better in the world, and he perfused humans. So he actually did egg counts on everybody at autopsy. And you find eggs everywhere. You find them in the brain, normally. You find them in the skin. You find them in conjunctiva. You find them in the cervix. They're everywhere. They don't always show up as granulomas, but they are actually everywhere. And you can actually find disease anywhere also. So that's really common. And pairs of worms, sometimes they're embolized as eggs, and other times the worms are just in the wrong place and they start laying eggs, and you get an acute infection right there. So you get inflammation preceded and then fibrosis. You have a typical epidemiology we'll get to in a second. Fibrosis is the end stage, and usually I'm not getting into pathophysiology, and I'm so out of date that I wouldn't want to tell you anyway. But it's supposedly a imbalance of the cytokines, like every other disease. So we're going to talk a little about Katayama fever. Katayama fever, I looked up 3 epidemics. And the first one was from Puerto Rico. Now, Puerto Rico is no longer endemic for schistosomiasis, but it was when I first started. And the epidemiology was that there were pits, excavation pits, and they were filled with water, and kids would go swimming in them. And during the course of the summer or disease, they would infect snails, which would normally be in any body of water, any reasonable body of water in this climate. And then they would have epidemics of kids that went swimming in these things. And, or actually somewhere else on the island. There was some, Puerto Rico was the first major area that was really studied very well. And it was very endemic. But not in the later 20th century. So this was a study by Bob Hyatt, who was epidemiology officer in Puerto Rico at the time. And at the time, no one ever treated schistosomes because you would kill a patient. So treating an acute schistosomiasis, and even chronic with the antimonic compounds that they had at that time, a certain number of patients would die. And particularly if they had acute disease. So the practice at that time was not to treat anybody. So here's a bunch of patients, some of which we saw at the NIH, that over time, untreated. So here you can see, so the patient comes in with fatigue, muscle aches, cough, rash, diarrhea. And clinically, in the tropics, this is diagnosed as typhoid fever. Except that it's not typhoid fever, because if you looked at their blood smear, they would almost always have eosinophilia. So what they have is they have huge, you can see their eosinophil counts here. Very high eosinophil counts, very high alkaline phosphatase. Alkaline phosphatase is the liver enzyme that is going to be elevated, if any, and that's because it's a granulomatous response. They have huge IgGs, and they have absolutely monstrous IgM responses. And as you can see, like a lot of the helminth and acute infections, this is ameliorated over time by itself. So the whole process is depressed. And this happens over the course of 2 or 3 months. This disease, when you interview these patients, they are done in. They can't move. they're sick, they may have a rash, they may have cough, they are really done it, and it takes a long time for these patients to get it. I was really impressed by how awful these guys felt and were. People can die from this, but that would be very uncommon these days. So, improving the literature, I came across this in I do weekly literature searches on most of the diseases I'm interested in. And this was a recent one, and that is very interesting to me for several points of view. So these were Dutch investigators that infected humans with single-sex infections. So they can remember there's male and female Cercariae, and they're male snails. So they basically infect snails with one egg, one Merocydia, and those are either going to be male and female, and they can figure out by molecular means whether they're male or female Cercariae, and then they infect those patients. And you can see, the first thing they did is you can see the Symmers dermatitis here, which they developed. And this is actually at the infection, the initial infection, you can get a history from patients of extreme itchiness. They are in the water, and before they, within minutes essentially, they're like rubbing their skin, don't understand exactly what's going on, and it could be a really, really bothersome symptom. And then later on, they'll develop this schistosome dermatitis. And these graphs, which I hope you can see, essentially the dark things represent, so these guys got 10, 20, or 30 Cercariae, and these were the symptoms that they got. Now, the thing to me was that this is a pretty low infection. 10 Cercariae is pretty low. We used to give mice, 100 Cercariae at a shot. 200 Cercariae. That was a sort of like a lethal infection. But nevertheless, you would give, you never would give them, 10 Cercariae, unless you were doing a very particular experiment. So this is a pretty low, and then we're developing Katayama fever. So that was the second thing. So we always thought that things were before egg laying, you got Katayama fever with the worms. This really proves it, because these are females. These were male infections, have nothing to do with eggs, and they were causing Katayama fever. And the number is very low. The second thing is that my first research was in developing the schistosome and understanding the circulating antigen schistosomiasis. And so I developed a number of assays. So my thing was on there were two antigens, a cathodic antigen that was circulating and a anotic antigen. And my deal was the anotic antigen. And this is a study that actually I did. I developed a Roseman's IFA test, and it turned out this antigen is localized to the gut of the schistosome, which you see here, and I devised an IFA test using fixed parasites, fixed that it happens to be a glycoprotein, and it's of course is impervious to fixation, and so you can use this as an IFA test. And I developed this. And the Dutch and the Swedes use this. It's the best way to make a diagnosis of acute infection. It's positive at 14 days. It's at high titer, and there's no cross-reactivity. And it's present in everyone. Unisex or bisex infection and all species. It fell into disuse for a number of reasons. So this was very interesting. And of course, they developed this system to understand about vaccination, because they've been trying to make a vaccine for this for 40 years, and they keep on trying, they keep on failing for a number of reasons. And so this is the most logical approach. The problem is people can get sick, and if you gave them dual infections, you gave them a bisexual infections, they could get ectopic disease, which is one of the problems you get. Now, the
Can I ask you a
epidemiology,
question with that last study? How many people, so they just used healthy volunteers and infected them? Did they comment on how many people they had to infect? Because again, some proportion of the healthy volunteers should be asymptomatic.
yeah, so it depends on, here, all the bars are individual patients. So you see the clear bars are asymptomatic.
Okay.
Okay, I should.
Yeah, no.
So the clear ones are asymptomatic. So the 10 on the left has more asymptomatic, and the 30 on the right have more. So they were using for most of their studies the 20.
It doesn't matter what gender, what sex the cercaria was that caught, they used only male. Or
They only use male because they didn't want to be confounded by egg excretion. You can't really, so whether, egg antigens or egg excretion.
Yeah.
I presume that was the rationale.
For the human, so it looks like to me that by some weeks after exposure, there's 3 humans, like on that first one, there's 3 humans, and at some point they all have some disease?
No, they don't have disease. None of these have nothing. They have no symptoms at all because they don't have any AEs.
And they just up on, okay.
These are AEs here. These are severe, moderate, and mild AEs. Just to mention, this is the performance. So the Dutch, this particular group in Leiden, and the head of it used to be a good friend of mine. And they're into carbohydrate chemistry in a big way. And this is what the levels of the anotic antigen are. So this is 30, this is 20, green, and this is 10. And you can notice that some of it starts before egg laying, which is at 4 weeks. So I was interested in this because the Dutch actually developed the cathodic antigen. Cathodic antigen is not really sensitive at low egg excretions. So you miss a whole bunch of very low egg, significant part of the population are infected, but very low, so you can't really detect any eggs in the way it's done. So now the anotic antigen, after 40 years, is now becoming into the 4, and it's a better assay. And so I was sort of happy about that. So the person who developed, actually the history is really interesting. So the person who developed the standard epidemiology and course of infection was a guy by the name of Kurt Klutzel, who was a German refugee who lived in Brazil. And as part of he was an engineer, he went back to medical school, and he was very smart, very brilliant, I would say. And he was sent to a very small town in northeast Brazil called Gamaleira. And there he spent his time looking at who had schistosome and doing physical exams and things. And he came up with this particular graph here. And what it shows is that this is the egg excretion rate below here. And this is the rate of splenomegaly. And you can see that the young are not infected until they have contact with water. And by the 10 to 15 years, they peak at, this particular community had a very high level of infections. This is 500 eggs per gram. This is a massive, pretty heavy infection in a community. And then about that time, they develop spleens. And then the egg excretion rate spontaneously decreases. And this is the standard epidemiology in an untreated population. No matter where you go in schistosomiasis and Manson-I for sure, Japonicum is, everybody's treated, so the whole thing is messed up. You can't really figure out what's going on there. But in Manson-I, this is what happens. So this is a different population in Brazil. And you can see that this is the intensity of infection here, and that I outlined in orange, and this is the prevalence. So the prevalence stays fairly high, almost approaching 100%, and everybody is infected in the community. So these are communities that go to the river usually, and washing their clothes, getting water, going swimming. they're doing all the things that people do who have a water supply, and they're all infected. So, but only a few are select to actually get really bad disease. So if you look at someone and most of the population, they all come to you with schistosomiasis. So you get all sorts of papers in the literature of, association of schistosomiasis with cancer of the colon, for instance. Everybody has eggs in the colon. You have cancer, you got eggs in it. And so everything is associated with schistosomiasis. So you have to sort of have an idea of what the epidemiology. So this is a paper that you're never going to see and is never going to be done again. This is at the time when there weren't any good ways of treating patients or easy ways of treating patients. And this was a prospective study in a population looking at what happens over time. And so this is Alan Cheever's handwriting here. So I can't remember the author of this paper. I think it was Continue. But at any rate, this is the age. This is the year, of course. This is the eggs per gram of feces. And you could say this is a 200, and then it goes to 300 a few years later. And this is a schematic of what happens in the liver. Now, the livers and schistosome are very different than normal livers. They're usually, they're increased in size in the developmental stage, and they're midline. So they're not on the right side. When I first examined them, Kurt Klutzel was laughing at me because I was examining in the way we do it here in the right side. He said, no, that's not the way you do it. You do it in the midline. And the livers are also hard as rocks. It's a little bosselated, and it's a very hard liver in endemic populations. The populations that you're going to see, they don't have hard livers because they're not very heavily infected, and you can not see these types of patients. But traditionally, they are hard, and you can see the spleens develop. Now, these are pretty heavy infections. I mean, this guy's got 900 eggs per gram, and then so there's also a variability. So one of the other things is if you do egg counts in persons, you say this has a higher egg excretion rate. First of all, there's a variability in what the stool is. So the stool could be loose, the stool could be firm, and so that's an inherent difference. The other thing is that because they could lose infections. So somebody who's low when you see them may have been very high, several years earlier. So that's it's only relative. How when you do a stool exam, it's only for that moment in time. So here's two things to mention. So this is just to demonstrate what happens. So in Manson-either, the eggs are laid in a linear array. You can see here as right here. And this is a higher power of some of that. You can see these are undeveloped eggs, so they have the morula right in the center. And this is just some examples of the granuloma. This is called a splendor, Hepley splendor, which is an antibody complex reaction that you can see in very exudative type of inflammation. This is taken from a patient that I was consulting on across the street. It's a Filipino that had a brain lesion, and you can see the chronic granulomatous, giant cells, and so on. And this is just to demonstrate the calcified eggs that you see in hematobium. In hematobium, you commonly see calcified bladders, calcified ureters. It's not the tissue, it's the eggs that are calcified. And they are actually outlining this structure. So the Symmers fibrosis is the unique form and to me, the pivotal clinical manifestation that you have to watch out for. So it is a macroscopic periportal fibrotic bands. And I'll show you some pictures. The liver function, in contrast to cirrhotic liver disease or toxic liver disease or viral disease, the liver function is well preserved. It's actually a plumbing problem. So it's a pre-sinusoidal block, and the patients will present with esophageal varices and they will bleed. If they survive the bleed and they don't infarct their liver, they'll do okay. And they'll do this repeatedly. And then one day they'll just bleed too much, they'll infarct their liver. The liver becomes arterialized because the blood supply from the venous system is no longer working. And so they'll lose their blood supply to the liver and infarct their liver. And death is from hemorrhage. Not so much, only in the end stage do they start getting ascites and other problems, or through other types of liver. Oh, really? Okay, so this is just showing you the fibrosis, the macroscopic. Again, the best way to make the diagnosis, and I did this study in Peru, in Sudan, is showing you the loss of the patency of the liver, large, and there's a whole thing. But at any rate, this is how you make the easiest way to make the diagnosis of whether they have Symmers. This is macroscopic. You see the major liver here, the fibrosis. This is just the MRI as another way of showing it, and so it's again it's essentially the pathophysiology is much further along these days, and we don't have to get into it. So just the epidemiology is repeated when you do the ultrasound, except that it's a much more sensitive technique, and it turns out that you get Symmers without liver disease because there's decompression of, and you don't get the esophageal varices. So this is just showing you the egg excretion rate, the egg excretion rate here, and the amount of splenomegaly. So it's the same type of epidemiology, except that it's exaggerated. So we went through the antibodies. So there's antibody tests, antigen tests, over-the tests, and DNA detection tests, which all work in acute disease. The best way is by antibody because you don't have to mess around. So a naive person gets infected, they always have antibodies. They have lots of antibodies, and you can detect it. The CDC does a Western blot. It's very sensitive, and they also do. It's also specific for the different species. The chronic antibody is a problem because a patient who comes to you from a chronic, you don't know whether they've had infection or they do have infection. So then you have to either do an antigen detection test, which is usually not available, or you have to look for the egg, or you have to presumptively treat them. So most of the time, they send the stool down or stool or urine down. The person more or less tries to figure out what to do with it. It may be insensitive, and everybody gives up and saying, well, maybe below the level of detection, and they just treat the patient. And that's usually what happens. One of the ways that the only thing you have to know is that you need to find eggs, you need to do a concentration technique. And the usual concentration techniques that they do in the hospitals is insufficient. So they do something called a Cato-Cats, which is a squash 200 milligrams of stool, and then clear the stool, and you can see many over in 200 milligrams versus 20 milligrams. This is the test as I described it, the IFA to the gut. This is the squash prep, so the squash prep is a way of making a diagnosis very quickly. That is, you take a blind rectal snips, you squash it between two slides, and then you look at it unstained, and this is the type of thing that you may see. And this is, of course, the antigen assay that we talked about. Treatment is praziquantel, and the problem with praziquantel is that it requires antibody to be effective in schistosomiasis, and that's why it doesn't work in acute disease. And so you have to wait to somewhat, or you could treat early and then wait. And in acute disease, you always use steroids because you can kill people otherwise.
How do we, sorry,
So I'm going to hang up.
Okay, we're here with part 2 of Dr. Ted Nash's talk on schistosomiasis. So we're going to resume that now. Take it away, Ted.
Okay. So let me get back to where I'm supposed to be here. So I'm finishing up on the Schistosoma mansoni part of this. And what I'd like to say here is that there are very few, and this is the only data that I know for what the mortality is, and for Schistosoma mansoni. And probably it's the only one for all the schistosomes as far as I can get, I know. But the Japonicum literature is, a lot of it is in Chinese, and so I have no idea what those data are. At any rate, as you can see here in this slide, if you have if you're infected, your chances per year of dying are 1 in 1,000. Once you develop fibrosis, it's 4 in 1,000. Then if you have varices, it's 8 in 1,000. And then once you start bleeding, then your mortality goes way up. Now, there are lots of very uncommon manifestations of mansoni and of the other schistosomes that are really a problem. And the most difficult problem is ectopic disease. Now, ectopic disease means that either worms or eggs or both are in an abnormal location. And the most serious abnormal location is the spinal cord and the brain. And this is apparently unrelated to the burden of disease. So in other words, if you have 1 worm pair or 10 worm pairs, you really don't, you're still at risk. Whether you're more at risk is really hard to say, but at least from a practical standpoint, you have to consider that this could happen. And this process, or this complication, determines a lot of your thinking on who you treat. Because normally in schistosomes, if you have a few worms, it's not going to do any damage to you in the long term as far as liver disease goes. But if you get that worm pair starts moving around and you get it in the spine, then you're in trouble. And this mostly happens, and so that's one of the decisions that you have to take into account when you treat someone. But you can get ectopic schistosome eggs anywhere. The skin, the cervix, they're essentially all over. Polyposis occurs in mansoni and is associated with protein-losing enteropathy. These are very heavy infections. And you can also get the same thing with hematobium in the intestine. The migration patterns of hematobium and mansoni are not exact, and so mansoni eggs actually appear in the urine, and hematobium eggs appear in the stool to a certain degree. There are a number of prolonged salmonella syndromes. The important thing here is that if you have mansoni, you have typhoid fever, you can't cure them, either of them, without, you can't cure salmonella fever without treating the schistosome, schistosomiasis. There's a urinary excretion of salmonella with and without fever. And this was described by Frank Neva from a previous chief of the lab when he was in Egypt. Pulmonary hypertension occurs in intestinal species, and this occurs when the ova can no longer, you have portal hypertension, and the ova never really at this point are shunted around the liver because they can't end up in the liver anymore, and they end up in the lung and eventually cause pulmonary hypertension. Glomerulonephritis is another uncommon but very well documented occurrence too, and this again is more common in those with liver disease, with portal hypertension, because the antigens are now being shunted away from the liver, not being picked up and ending up in the kidney. And then there's Bilharziomata, which are basically large proliferative masses of schistosome eggs. It's an inflammatory mass that mimics tumors. So it's not uncommon to hear about a person that has schistosomiasis and thinking that it's actually a tumor, a colon tumor, and essentially it's a Bilharziomata, and they take out the colon by mistake. So now we're going to go to Japonicum. Now, my problem with Japonicum is that the period of definition of the epidemiology really occurred, it pertains to Mansoni. And whether it pertains to Japonicum is sort of assumed, but by the time people started studying it, almost everybody was treated. So the prior epidemiology was in untreated populations. And in Japonicum, just about every population, not everyone, but most populations have either had access to drug or were given drug repeatedly. And so really so I have a problem with understanding what is a high egg burden versus a normal egg burden in general. But so Japonicum, nevertheless, is the most virulent of the schistosomes, and there's some things that are very different about it. The most pertinent is that it's an enzoosis, where Mansoni, although it goes into other animals, it plays no really important role in the transmission. But in Japonicum, the snails are lived in, they like mud, and so they like wet environments. They don't actually need running water. But so you have acting as reservoir hosts, you have buffaloes, pigs, dogs, rabbits, rodents, and other animals. And this is important because you can't really control the disease unless you treat all these animals, because they are excreting ova, which are going to then infect snails. And then if you get around, if you're infected, you can be infected from that. So they also lay more eggs than any other, and they're laid in clutches. And so the disease tends to be much worse and more virulent. And it also, in contrast to Mansoni, once you're infected and you develop, let's say, Katayama fever, you can develop it again. So in the original descriptions, it's someone goes into an endemic area. Usually it was a wife of somebody from marrying someone in an endemic area. They had a disease which had a fulminant course fairly quickly. And so the epidemiology of this decades course was telescoped to something much shorter. Exactly how short is really unclear. So the CT shows typical turtleback calcifications that which is shown at the arrow. And you can see the liver is somewhat bosselated. It doesn't show the fibrosis as that you see either in MRI or ultrasound. The other big difference in Japonicum is that although Mansoni and hematobium tend to go, when they have ectopic disease, they tend to go to the spinal cord, Japonicum tends to go to brain. And here are just two examples. So in the acute Katayama fever, something, if I remember correctly, something in the order of a few percent, 3 to 5%, will develop brain lesions in the setting of Katayama fever. On the left is a patient that I reported, And this was an American who was visiting his Filipino wife's family and went swimming with them, where he got Katayama fever. They, of course, didn't. And you can see, and he was not diagnosed until years later, but this was the acute CT scan that he had. We only had CT scans at the time. And you could see it's a inflammatory process with edema, which is the black area. On the right side is a chronic, so they come in two varieties, the brain lesions. One is associated with acute disease, and the other one is usually in the years after infection. The patient is generally asymptomatic, and they present as brain like brain tumors. And you can see the pattern here is also an inflammatory with edema. And these are usually, they have no systemic symptoms at this time. They just have a mass. And you want to at least consider the diagnosis. And we had a case that was at Walter Reed at some point, and maybe in the late 70s. And that patient was a Filipino, had paragangliomyces, and also had was felt to have TB because the parents had TB. And they whacked off part of her brain only to find out it was japonicum.
Can I ask another clarification question? Just how quickly in the acute process does it take the eggs to calcify? So if you have a patient that you're suspecting acute schisto on, and they have some sort of neurologic problems, would you expect fairly soon to see a CT scan light up like that with the calcification there, or does that take some time?
The CT scan, it doesn't. This one does not show calcification. That's that probably from the dye or something like that. No, I would expect it to take it takes time.
Okay.
But how much time, I don't know the data.
Okay, that's helpful. Thanks.
So hematobium is again very different than either Mansoni and Japonicum. And of course, it goes to the urinary tract system, but not only the urinary tract. It has an imperfect homing system, and so it goes to other organs as well. But the colon, as I mentioned earlier. For a long time, it was unclear whether Katayama fever occurs. It does. Another difference is the pre-patent period, which is prolonged. So here, you may have to wait for 2 or 3 months in order to find the ova in the urine in order to confirm the diagnosis. Symptoms are common both in travelers and endemic populations. And as I said, it's a GU tract involvement, but cervical ovarian involvement in the male GU tract is very common. The epididymis, for instance, is probably the most heavily has more eggs per gram than just about any other organ. And the hematuria is universal and is a surrogate for infections. And as a matter of fact, in endemic areas, the onset of hematuria in the male was felt to be something like menstruation in the females. Unlike Mansoni, once you get disease or infection, you generally are symptomatic, although you can be asymptomatic in low infections. But dysuria and hematuria occur, and they keep on occurring. So there's not this distinct silent period. Of course, you die from actually two things: obstructive uropathy and renal failure, of course, and then tumors of the bladder are one of the sequelae of this infection. The epidemiology is very similar to Manson-I, and that, as it shows here, there's a high peak in prevalence occurring during the first 2 decades, associated with an increase in intensity in the first 10, 15 years, and then a drop-off in intensity. The drop-off of both the Manson-I and hematobium is hotly debated, and there were whether that was due to decreased exposure as you got older and didn't go swimming as much, or was it due to immunity? And the general feeling is, without going into the data, by doing very crude basically it's you have citers looking at people who are going into the water and trying to quantify the type of exposure, the time of exposure, and the nature of the exposure. When they do that, they sort of get a partial immunity that they think develops to account for this. But the epidemiology is more is similar. Now, the other thing I should mention about diagnosis, there's a standard way of making the diagnosis, and that includes is taking a noon urine, 10 cc's of a noon urine, and centrifuging it down and counting the eggs, or in some manner. Now, the reason you do it at noon is because if you wake up in the morning and then start moving around, the eggs are sort of shaken off of the bladder. And so that the maximum occurring is at noon if you wake up in the morning. If you're a night person and don't wake up until 6 p.m., then you do the urine at midnight, more or less. So that's the reason for that. This is all of these are is what the old parasitologists did for for work. It's very it's nice to know, but it's pretty it's pretty logical. And this again shows the intensity infection is gives you more blood loss. Again, here's the top graph shows an increase in prevalence in males in particular, with a peak at 10 to 20 years. And then the bottom graph is just shows a series of graphs going from the bottom one which is low burden, and the highest one is high burden, showing that you have more hematuria. So in the chronic disease, you have hematuria, dysuria, you have hydrouria or hydronephrosis, polyposis. And the difference between hematobium is that one pair in the ureter can give you renal disease and hydronephrosis. So this is one disease that at least in my practice, and I always treat hematobium. It happens to be the easiest of all the schistosomes to treat, but nevertheless, even if I find one live egg, it's enough to treat. So the eggs of hematobium and also japonicum, as I mentioned earlier, calcify. And so you get calcification of the bladder, seminal vesicles, ureters, stones, and also you get stones and salmonella syndromes. And in women, you get genital ulcers in women, and increase in venereal disease and HIV transmission. So here are a bunch of pictures. So the type left one is a child who died in Egypt in an automobile accident. And what you can see are several nodules, and these are polyposis that is very focal. And this is the way, and you always look for that in the bladder, usually by ultrasound. And the right is an acute disease. You can see many, actually most of these are eosinophils, and you can see some ova in the mucosa. On the left is a patient who died from, the bottom left is a patient who died from hydronephrosis and renal failure, which is actually relatively uncommon. So in prospective studies, they tried to figure this out, and it's surprisingly how few people actually die of renal failure. The left kidney has been deflated, and the right kidney is the one that hasn't been manipulated. The top bottom shows a very interesting study of essentially of bladder cancer, which is shown in that mass on the bottom of the middle slide. And then it also shows you the bladder and the calcifications in the mucosa. Now the calcifications are actually the eggs. It's not the tissue per se. It's the ova that are calcified, and you can see this in the X-ray of that particular section, and you can see the which is on the right. And then in another series of old burnt out disease, you can see the hydroureter. You can see a ureter involvement in the mucosa, and you can also see another picture of another ureter with the calcified eggs. So, so there's also the inflammation early on is very exudative. And then it leads to non-inflammatory lesions, which are usually called sandy patches, and that means that if you rubbed your finger around on the tissue, it was sandy, which was basically the eggs in a non-inflammatory background. With very little inflammation. The ova, as I said, tend to calcify. Early exudative lesions are reversible with therapy, but once they become fibrotic, like some of the pictures I showed you just earlier, it becomes reversible. Squamous carcinoma is sequelae, as I showed you in the carcinoma, and this is one of the major complications of this infection, and another reason that you tend to treat any infection. The hematobium does tend to go to the spinal cord. There are uncommonly, it can cause brain tumors, just like japonicum, squamous carcinoma, bladder stones, cor pulmonale from shunting of the ova. Renal failure is not that common. As I mentioned, about 6% in an autopsy study. So that's actually a very biased study. So it's really fairly uncommon, at least hard to show. And in prospective studies, it's uncommonly documented. Renal failure is uncommonly documented. The diagnosis, just like japonicum and Manson-I, it's easy to find antibodies, and any antibody that is basically positive in a naive person makes the diagnosis. The standard method, as I mentioned, is a noontime urine examination. Hematuria has been a surrogate of infection for as long as it's been studied, essentially. The urine antigen assays, of course, are positive, just like in japonicum and in Manson-I. One needs to assess organ damage, maybe polyposis in the bladder, and you treat with a single dose of praziquantel. And I would reevaluate in 2 months to 1 year. So what happens when you treat is that the worms praziquantel causes immediate contraction of the worm, and they start laying. Now, if they're not killed, then in about 2 months, by 2 months, they will start laying eggs again, and you will be able to pick up. If you look for eggs shortly after you treat, you don't know whether you're dealing with stunted live worms that are going to re-lay eggs or refresh themselves, or they're actually killed. So that's why you have to at least wait a little. The other thing to note is that there are so many eggs in the bladder that they will shed dead eggs. And dead eggs to a novice look the same as live eggs. So you have to actually, know your business here. Just finding an egg, you have to know whether it's a live or a dead one. And a dead one is crenated a bit, and you don't see a good miracidium in the center of it. You can't really make it out that well. Where a live one has, well, first of all, sometimes they hatch right in front of you when you're examining them, and particularly in urine if it's dilute. And then the other thing that happens is let's see, well, at any rate, I think I dropped the thought, but at any rate, the other way of looking at live eggs is by looking at the flame cells, which is an excretory organelle that you can see at high power within live cells. I think that's all that I had to say. This is just a prior slide that I took out. Okay, Elise.
Thanks so much, Ted. I think that was great. We appreciate you coming. I guess we will stop the recording.